Okay guys, Timmy coming at you here today, and today I'm going to talk to you about heart block. Now, there's several different kinds of heart block. So what I'm going to do is talk to you about Mobitz 1, Mobitz 2, and complete heart block. Now, let's look here. In Mobitz 1, it used to be called Winky block. I don't know if it still is. But in Mobitz 1, there is a progressively elongating PR interval. So you move from a relatively normal PR on your first beat. Then your next beat, the PR interval starts getting wider. And then progressively wider, longer, until there's a P wave which does not conduct a QRS. And then there's a delay, and then it starts all over again. So basically what's happening is there is a block that's occurring. Hang on. That's occurring higher up in the AV node. So this block that's occurring higher in the AV node is delaying the electrical impulse from the atria. That's what's causing the prolongation of the PR interval until that delay becomes long enough where it simply does not conduct a QRS complex. And that's usually benign. It can be the result of some medications, but that's really not that troublesome. What is troublesome is Mobitz 2, second degree heart block. Now what's happening here is you have a relatively normal PR interval, and it will conduct a QRS normally, and it's regular. And then you will get a P wave at its normal interval, but it will not conduct a QRS. And if this happens every second beat, where you get a normal P wave followed by a QRS and a T wave, and then a P wave that doesn't conduct, then that's referred to as 2-to-1 heart block. Now, what's important to remember is in second degree heart block, type 2, Mobitz 2, what's happening is that the problem is farther along in the AV node, or it might even be in the bundle of His, but there's definitely an organic problem going on. There's something wrong with the conduction system of the heart. And in second degree heart block type 2, Mobitz type 2, this usually will degrade to complete heart block or third degree heart block. So if a patient is in this rhythm, then a doctor is going to set up the person to get a permanent pacemaker, because it will ultimately degrade to third degree heart block. Now, in third degree heart block, the name pretty much says it all. It's complete heart block. So basically what's happening is there is no connection electrically between the atria and the ventricles. So the atria will fire at their own rate, and then because the ventricles aren't getting the signal from the SA node through the AV node, then the ventricles are going to fire off on their own, right? The Purkinje fibers are going to take over. So in third degree heart block, the atrial rate is faster than the ventricular rate. And because the Purkinje fibers are producing the electrical impulse, it's not going through the quicker normal electrical impulse. The Purkinje fibers are depolarizing the ventricles, so it's kind of going through a goofy pathway. The QRS complex in third degree heart block is much wider because it's taken a goofy conduction. So if you were to march the P waves out, there's a P wave here, and there's a P wave right here. It's kind of jacking in the T wave a little bit, you know. And these intervals should march out. Then, if you look at the QRS complex, they'll march out. But you're getting basically 3 P waves for every QRS. And there's really no relationship between it. Look, here's a P wave, then you get a QRS. Here's a P wave, no QRS. Here's a P wave, and then look at, there's this space here. So the atria are conducting impulses on their own, and the ventricles are conducting impulses on their own. And there's no connection between the atria and the ventricle. And again, because the Purkinje fibers are the pacemaker for the ventricles, and because it's going through kind of a goofy pathway, the QRS complex is wider. So the heart rate is going to be between anywhere from 15 to 30 for the ventricles, and it may be 60 to 80 for the atria. So that's how you determine third degree heart block. What you really do is you look at the ventricular rate, and then you look at the QRS complex itself. So if you look here with the AV blocks, you're getting normal conduction once the P wave conducts. So you get the P wave, then you get the normal width of the QRS. And the reason you get that is because it's taking its normal pathway. But some of those P waves are simply not conducting through the AV node, bundle of His, left and right bundle branch, to depolarize the ventricles. So always remember that Mobitz 2 is a serious problem, and 2 to 1 heart block, Mobitz 2, both serious. Mobitz 1, not that big of a thing, benign, but those are heart blocks. And understanding that will help you. I hope this helped. This is real quick. Oh man, was it? Oh yeah, I recorded. All right, see ya.